Okay, good morning. So here I'm going to show some findings we've made on colorectal cancer mortality and about the screening of that condition. And so colorectal cancer is in Europe the second cancer, I would say, and it affects both males and females. And in Europe, about 400,000 people are diagnosed with colorectal cancer every year. So it's quite a big burden of disease. And this busy slide shows you, in fact, on the decrease, what is the changes in the mortality from colorectal cancer in all the European countries, 31 countries, from 1989 to 2010. And what this slide shows that on the top level you have all bars going on the left side. These are the decreases, the countries where you have a sharp decreases in colorectal cancer mortality. Whereas on the bottom of these slides you have the bars going on the right, and on the right means that the colorectal cancer mortality is still on the increase. These are the European countries, so it shows that it goes the variability in trends in colorectal cancer mortality in all European countries, and this alludes to what my colleague Philiipe had just showed before, the huge variability in cancer mortality across European countries, and we have the same for breast cancer and so on. But this shows how the diversity we have in Europe concerning mortality from cancer. We don't have that, for instance, in the United States. That's something quite unique in the world. So that's the huge variability in Europe. And this variability, if we focus on some countries with quite, say, relatively wealthy economy, we see there that there is quite a difference in the trends in mortality from colorectal cancer, starting on the upper left with Germany, where you have considerable decrease in colorectal cancer mortality since, say, 20 years, with minus 35% among males, minus 44% among women. And then as you go down from left to right and down to the slide, you see that at some point you have, even in the Netherlands, you see that the Netherlands, for instance, does not enjoy such a decrease in colorectal cancer mortality, not as much as Germany or France, for instance, or even Belgium. And then you have Greece, where in fact colorectal cancer mortality is still on the increase. Of course, we could ask ourselves why there is such a discrepancy, apart from socio-economic, economic wealth, and things like that. Is there something else that could work? And here we come with the screening. And then on this slide, just to illustrate what screening is trying to do with the colorectal cancer, and you have two types of screening, basically. One is trying to catch the cancer when it erupts. The cancer is invading the intestine, the large bowel, and then you have some blood that is leaking in the stools, and that these are the fecal occult blood tests, searching for blood in the stools. And then you have on the left side of the slide, you have detecting polyps. Polyps are precursor lesions of colorectal cancer. So these polyps are not bleeding, but you can catch them with endoscopic techniques. You go with a lumina, and then you can catch them, and you can remove them with endoscopic techniques. So basically, that is the other endoscopic technique-based screening for colorectal cancer. And just to say that in any case, whatever you do as a test for colorectal cancer, it ends up, when it's positive, suspicious, always in a colonoscopy. That's to say, a full examination of all the bowel with an endoscopic technique. And just to say that these screening tests have all been tested through randomized trials, just provide the best evidence for efficacy. And all these trials, 8 trials, have shown, done in Europe, done in the United States, have shown that screening for colorectal cancer is really able to decrease the mortality from colorectal cancer. Of course, we ask ourselves, do we find that across populations? And it's good to see in the trials, it's one thing, but do we find that evidence across population? And then we found for 11 countries in Europe comparable data on colorectal cancer screening, which is rare, because comparable data means that you got information from standard questionnaires with the same way to collect the data. And then, of course, we compare that with mortality from colorectal cancer. And this is the main finding we have done, Again, sorry for this complicated slides, but just going through shortly just to say that what you have on x-axis is the percentage of adult people who are 50 plus who have ever had an endoscopic examination. So it means that, for instance, if you take France, for instance, in France with FR, you have about 30% of adult people 50 plus who ever had a colonoscopy or a sigmoidoscopy, generally. That's what the point of France. And then on the y-axis, what you have the change in colorectal cancer mortality over the last 20 years. So that's you have the change from, say, 89 up to 2010. And what we can obviously see on these graphs is that the higher the rate of having had an endoscopic examination, a screening, the greater the decrease in colorectal cancer mortality. You have it both for males and females. And again, when we look at some countries where I just showed before, for instance, you have the Netherlands, you have NL, Netherlands, where we have seen before a very small decrease in colorectal cancer mortality, but this is paralleled by a very low amount of endoscopic screening. Whereas when you take countries like France and also DE, which is Germany, in fact, you have quite a strong decrease in colorectal cancer that is correlated with a very high proportion of people who submitted to endoscopic screening. And just to say what about other screening like fecal occult blood tests, they work too. The fact is that here, this graph, we just plotted together those who had passed a fecal occult blood test with those who had an endoscopy, and it's practically parallel. So both tests, all these tests are working, I would say. So I don't want to make any difference between the tests. I just want to underline that they're really effective within populations. And our conclusion is that really the cancer colorectal screening is really contributing to the decrease in colorectal cancer mortality and is probably working as well as for cervical cancer screening. So potentially it's a cancer for which we could make huge strides in decreasing the cancer mortality through screening, and would be much better to divert and to direct target resources we have towards the screening of such conditions like colorectal cancer, cervical cancer, and less resource to cancer screening where it's far more controversial, like the breast cancer or even more worse, the prostate cancer screening. Thank you very much.
Great, thank you very much. And now I'll open the floor up for questions. One down here. And could I just remind you to say who you are and who you're writing for, please, before you ask a question. Thank you.
Thank you. Hello, I'm Kate Kelland and I work for Reuters. This is a question for Philiipe Autier. It was to pick up on the last point you made. Is in this kind of screening, in this kind of cancer, what are the risks of overdiagnosis and treatment that could cause more harm than good?
Thank you for the question. The good thing with the cervical cancer screening, because both are important, cervical cancer screening and colorectal cancer screening, there is practically no overdiagnosis. That's to say the risk of being diagnosed with a cancer that is not life-threatening is very small, if not non-existent. Whereas in breast cancer and prostate cancer is very high. You know it. Why is there such a difference? Sorry. The difference lies in the very peculiar aspect of screening, that to say, in cervical cancer screening and colorectal cancer, you have a precursor lesion. Cervical cancer, you have the CIN on the cervix, and in colorectal, you have the polyp. These are not cancer, but when you remove them, you prevent the cancer. So you don't have such overdiagnosis. Whereas in breast cancer, prostate cancer, you don't have precursor lesion. You have something that is called a cancer, at least under the microscope, even though it is not life-threatening, unfortunately. That's the way. So you have really the difference between cancer where you have precursor lesion and those cancer without precursor lesion. And when you have precursor lesion, that's the best scenario for screening.
Can I just ask for a little bit more explanation? So there is no doubt that those precancerous lesions will turn into cancer, will become cancer.
Ooh, that's another leap.
I'm really asking whether there's any similarity between
most of these precursor lesions will never turn into a cancer. Most of them. But the systematic removal of these precursor lesions will avoid, of course, some of them turning into a cancer.
I see.
Okay. Of course, we'd never know in advance which one is going to turn out in cancer. So the best with gynecologists or with gastroenterologists, we remove everything that we see. That's the current policy.
Charles Bankhead, MedPage Today. I have a question for Dr. De Bruin. Were you able to separate out the effects of obesity in your study? Because there could be some overlap in that obesity has been associated with some of the cancers that you were looking at. Were you able to control for that or separate out the effect of obesity?
Yeah, it's indeed correct. Obesity is a risk factor for certain types of cancer. The studies we included corrected for, they had adjusted hazard ratios, as it's called, in their study. But what we did in our meta-analysis is we took the unadjusted hazards and pooled them, because overall all these studies together did not adjust for all the same things. So if we did pool them together, then it would be comparing apples and oranges. So in our meta-analysis, the overall outcome is the unadjusted hazard, so it's not corrected for BMI. But the individual studies, well, some studies do correct, but it's really important to indeed do so, because indeed BMI and obesity is a risk factor for cancer. Yeah.
Helen Saul from the European Journal of Cancer. Dr. Ades, your figures were on overall spending. Do they tell you anything about the spending on screening as opposed to treatment, or would you expect that to be a similar proportion, or was that taken into account?
Indeed, this is a limitation of our study. We just look at the overall expenditure in health. We didn't look for specific cancer budgets or screening budgets, even because this information is not available online and not available publicly, so we're not sure if we could compare them. So this is indeed a limitation, just overall budget in health.
Pierre Doel from Belgian Oncology News. Dr. Autier, on the screen we see that less for mammography and screening and PSA testing. So could you answer to the question? The question for Dr. Ades is, yes, we don't know what are the expenditure for the cure, the screening, but you say that we have less to allocate for the screening on mammography and PSA testing. So.
Yeah, okay. I don't want to enter in a debate, but the fact, if you look at the cost of screening versus what you get in terms of reduction of mortality. At present, it seems quite clear that for every euro or dollar or sterling invested in screening, the return is far better for screening like cervical cancer screening, and probably even better for colorectal cancer screening. So it's quite cost effective, I would say. Whereas for breast cancer screening, depending on what we expect from in reduction of mortality, and that's debatable, then the cost effectiveness is much lower. And if we look for prostate cancer screening, and there are several presentations during this meeting about that, there it's even worse. We are really spending money for doing a lot of harm. So if there is policy making to do at this stage, I would say that targeting precursor lesions with screening is probably has a better economic yield than looking for trying to catch small cancer, invasive cancer. Moreover, never forget that screening for colorectal cancer and cervical cancer screening is also able to decrease the incidence of this cancer. So the number of women presenting with cervical cancer or men and women presenting with colorectal cancer, thanks to screening, is going to decrease the number. Whereas screening for prostate cancer and for breast cancer, you increase the numbers of patients. So you have a paradoxical situation here that makes the world of screening is not a simple world. It's not a panacea. And targeting these precursor lesions is far better in terms of patients, for the patient themselves, but also for the economy.
Desmoulins, Medscape France. This is also a question for Professor Autier. Can you precise what comes from the blood test in the stool and what comes from colonoscopy? Because, for example, in France we have a protocol. We first have to do the blood test, and these blood tests have been criticized because there is face negative. So.
Yeah, yes, that's right. Being working in France, I know the heaviness of the French administration in that. But at this stage, I would say the choice that has been made by many governments to go with the fecal occult blood test, there is no criticism because it's working anyway. The problem is that it's quite cumbersome for many patients because anyway, if the test is positive, you have to go to colonoscopy. And in many settings, in fact, we just look at fecal occult blood test as just being a way to indicate those patients that should go to a colonoscopy. And when I say patient, these are not patients, but healthy people that have to go to, it's only a way to select. So some countries, like it's clear in Italy, it's also in Germany now, people have more and more the choice to select what they want as a screening policy. Because behind also FOBT, fecal occult blood test, or endoscopy, you have always an issue of acceptance. It's not people may be more willing to go to one test or more willing to go to another test. So I think that here, I like very much what some people at the American Cancer Society are saying, is to say, do something. You have the choice. What is important is to do something. You have colonoscopy, you have flexible sigmoidoscopy, you have other. So what is important with colorectal cancer is to do something. There is sufficient evidence that all is working. Probably that endoscopy is ultimately the best, but I would say subjects who want to go to a fecal occult blood test because they don't like endoscopy, it's a good choice.
Hello, Kate from Reuters again. I was interested in, Professor Addis, your study, something that you didn't really focus on, but the fact is that incidence of cancer also rises with spending on healthcare, which may well be obviously a proxy for GDP wealth. Does that, can you say something a little bit more about that in your
Actually,
you don't focus on that much in your study?
Actually, we look at it, but as I had short time, I didn't put in the presentation, but it's in the article. Actually, this was one of the discussions when we compare mortality incidence between all cancers and breast cancer. So when we look at the big picture of all cancers, the best divider between East and Western Europe is mortality. You see that proportionally, mortality is higher in Eastern Europe than in Western Europe. But when you take only the case of breast cancer, it's very clear that what divides both blocks is incidence. So you see an increase in incidence in Western Europe. And we are not completely sure that this is because of screening, but there's a big chance that the screening plays a role in the increase in breast cancer incidence in Western Europe. The thing is it, as Professor Autier said, is this a real increase of breast cancer or over-detecting? We're not sure. This is and what we call over-detection of breast cancer. Is it in situ lesions? So there are some I'll say scientific doubts towards characterizing what is over-diagnosis in breast cancer. But indeed, the incidence of breast cancer, as we characterize today, it increases with health expenditure.
And that's discussed more fully in the Annals of Oncology paper.
Yes, exactly.
Yeah, so yeah, do come and get it from us afterwards. Are there any other questions? Perhaps we go down to the left here. Thank you.
Patrice Wendling, Oncology Report for Dr. De Bruyn. What percentage of patients in your studies overall were on metformin and insulin? And if you didn't adjust, how might that be affecting your results?
Yeah, we don't know how many patients use metformin or insulin because the included studies did not account for use of medication. So we have no idea. So we couldn't, we didn't adjust for that in our overall analysis. So that's why I said future studies should really adjust for medication because it's indeed really important. But we're not sure what the effect would be because metformin is protective or is said to be protective, and insulin is said to increase the risk even more. So yeah, we're not sure what the overall effect would be because you have otherwise on the one hand metformin and on the other hand insulin. So maybe they level out, but yeah, we don't know.
Okay, Helen.
Helen from EJC. For Philiipe Autier, do you think there is the political will to shift money from breast cancer into colorectal cancer screening? It would be very controversial in the UK.
Yeah, I know. Colorectal cancer is a far less political cancer than appealing cancer than breast cancer. But here we come really into a more political question than anything else. So that's beyond the science.
Lynn Peterson with Trends in Medicine. So Dr. De Bruin, am I missing something? But you don't know whether it's the diabetes that raises the risk or the medication they're taking?
Well, no, it is. Studies show that really diabetes shows to be a risk factor for developing cancer.
From your study?
Well, no, also from other studies.
Right, but from your study, can you make that determination?
No, because the studies we included did not adjust for type of medication, so we can't tell whether it's, what the influence of the medication is in our study. But
so it might not be diabetes, but it might just be the medication they're taking.
No, probably not, because it's multifactorial, and it's just the diabetes really. What I didn't said to your colleague earlier is that what I told you, we used unadjusted hazard ratios, but we also did a sub-analysis where we put the adjusted hazards together. So we adjusted for BMI and everything, but not medication because the studies did not account for that. But still, this risk remained increased. So it was actually still diabetes that accounted for an increased risk. But what I told you earlier, the studies did not account for the same thing, so it was not a really fair comparison. But this really points out in direction that diabetes is an independent risk factor for cancer and mortality.
Okay, are there any other questions? No? Okay, then thank you very much all for coming, and if you want to have individual conversations afterwards, please do. Thank you.